بسم الله الرحمن الرحيم. الحقيقة يعني من سعادتي البالغة حضور مؤتمر Hepatology On The Nile طب الكبد في أحضان النيل. والحقيقة يعني أنا ببارك لكل الناس اللي حضروا وهيحضروا إن شاء الله فعاليات المؤتمر. وأنا يشرفني وجود دكتور أحمد فرج القاصد الزميل العزيز ونائب رئيس جامعة المنوفية لقطاع الدراسات العليا والبحوث، وهنسمع منه كلمة في افتتاح المؤتمر.
بشكر سيادة العميد. بسم الله الرحمن الرحيم، الصلاة والسلام على سيد الخلق أجمعين سيدنا محمد عليه أفضل الصلاة وأتم السلام. أولا كل سنة وحضراتكم طيبين، نص شعبان ورمضان على الأبواب، ربنا إن شاء الله يبلغنا رمضان بالخير إن شاء الله. مؤتمر معهد الكبد Hepatology On The Nile علامة أساسية وما ينفعش يتفوت، وكل سنة بنشوف فيه تطور أكتر وكل سنة أحسن من السنة اللي قبلها. أما أخويا العزيز دكتور هشام، أولا دكتور هشام يعني زميل كلية، احنا قصر العيني فرق بيننا دفعة تقريبا، وأما قال لي احنا ميعاد المؤتمر أنا اضطريت وكنت سعيد إن أنا ألغي التزامات أخرى كتير، لأن لازم أجي المؤتمر، ما ينفعش أي حاجة تانية تتفوت لأكتر من سبب. أولا ده جزء من شغل الدراسات العليا، ثانيا بقى انا في الحاجات الطبيه بحن لها بصراحه، فما ينفعش يبقى عندنا مؤتمر طبي وبهذا الشكل انترناشونال وعندنا اكتيفيتيز بالشكل ده وما يبقاش ممثلين فيه وما يبقاش حاضرين معاكم وداعمين ليكم. انا لسه بقول لسياده العميد، انا من امبارح متابعه على الفيسبوك وشايف الاكتيفيتيز الورك شوب اللي انتوا عملتوه، وبهنيكوا على اختيار المكان اللي عملتوا فيه الورك شوب. ده تشجيع للسياحة في بلدنا وتشجيع لان احنا حتى نعرف ايه معالم بلدنا. انا كان نفسي اكون موجود امبارح، انا ما روحتش الحقيقة متحف الحضارات وكنت اتمنى الفرصة ان انا اروح، ولولا الظروف امبارح والله كنت هاجي واحضر معاكم اليوم حتى عشان اشوف المتحف اخباره ايه. اتمنى لكم مؤتمر موفق، وانا متأكد انه هيبقى بالشكل ده. والحقيقة قبل ما أختم كلامي لازم أثني على معهد الكبد، ودي مش شهادة مجروحة، بالعكس أنا هتكلم كلام فعلا من قلبي أنا مقتنع بيه. معهد الكبد القومي معهد فريد من نوعه، ويتميز عن أي مكان آخر في الجمهورية. حتى الأماكن اللي بتشتغل هيباتولوجي إحنا أميز منهم، مش أميز منهم عشان إحنا اللي كنا بادئين، واحنا عندنا الامكانيات العاليه جدا وعندنا التراك ريكورد والبروفن ريكورد بتاعنا موجود. احنا المنشورات الانترناشونال في بابليكيشنز وحاجات Q1 وQ2 رانك كويسه من معهد الكبد عاليه جدا. احنا في الجامعه بنعتبر المعهد وانتاج المعهد هايل، وده بيحط دايما لما يبقى في مكان البرفورمانس بتاعه عالي بيخلينا كل شويه بنرفع البار، زي الرياضي كده اللي بيرفع اثقال او اللي بيعمل ارقام قياسيه، كل ما يجيب رقم يبقى باصص للرقم اللي بعديه، كل ما ياخد خطوه يبقى باصص للخطوه اللي بعديها. فعشان كده دايما تطلعاتنا وتوقعاتنا من معهد الكبد ملهاش سقف، ونتمنى ان شاء الله ان ده يستمر، وانا متاكد انه هيستمر. وفي كل مجالات اللي بتشتغلوا فيها على فكره، مش بس البيور هيباتولوجي، في التخدير الببليكيشنز بتاعت معهد الكبد عاليه، في الهيباتولوجي في جراحات الكبد والهيباتوبيلياري سيرجريز. يعني الحقيقه ده شيء فخر لينا في جامعه المنوفيه ان يبقى عندنا كيان بهذا الشكل، ونتمنى منه اكتر واكتر المزيد على مدار الفتره الجايه ان شاء الله. وانا متفائل جدا ان ده هيحصل بسواعد ابناء المعهد اللي بيحبوا المعهد ونفسهم فعلا يوصلوه لاعلى المراتب. مره تانية انا برحب بيكم وبشكركم على دعوتي الكريمه، واتمنى لكم مؤتمر موفق ان شاء الله. شكرا، السلام عليكم.
بنشكر أستاذنا الدكتور الأستاذ أحمد فرج القاصد على تشريفه لينا، والحقيقة احنا ممتنين جيه لاهتمامه بالمؤتمر وحضوره لينا النهاردة، ونستأذنكم إن احنا نبدأ السيشن الثاني.
Now we'll start the third session, viral infections of the liver and GIT, and I invite Professor Said Abdelail, Professor Mohammad Miligi, and Professor Mohammad Abdel Samia. We have a little change in the written program. We have Professor Maria Butti as a first speaker instead of Dr. Tariq Asila. Professor Maria Butti is a clinical chief of hepatology, chair of EU policy and public health of the European Association for the Study of the Liver Unit, Hospital Universitario Vall d'Hebron, Barcelona, Spain.
Sukram, thank you very much for your kind words and for the kind invitation. I would like to thank Nagla, Alan, and Professor Iman Walker for inviting me again to the Hepatology of the Nile. I am very, very happy to be here today in these difficult times, particularly difficult for Europe with the Ukraine war. And Israel is clearly supporting all the Ukrainian citizens, and particularly we are asking everybody to help the Ukrainian refugees living in other countries with liver diseases. I am going to talk about hepatitis E, an often under-recognized viral hepatitis with a wide range of clinical manifestations. These are my disclosures. Hepatitis C virus is the most common cause of acute viral hepatitis worldwide. It's a single-strand RNA virus discovered in the early of the 80s. It belongs to the Hepatiridae family, and there are at least 8 Hbv genotypes. And this virus can cause acute, chronic, and fulminant hepatitis. The distribution of hepatitis C virus is worldwide, but there are 4 genotypes, 1, 2, 3, and 4, that infect human beings. And as you can see, in the majority of European countries, the most frequent genotype is genotype 3. And here in Egypt, there is genotype 1 and genotype 3. What is important, the differentiation between genotype 1 and 2 and genotype 3 and 4 is because genotype 1 and 2, the main route of infection is fecal oral throughout infected water, and usually produce clinical outbreaks of hepatitis E, and particularly affect mainly young adults. There is no chronic infection with genotype 1 and 2. It could be second infections, and it's associated as genotype 3 and 4 with extrahepatic manifestations. Looking at the outbreaks of hepatitis E, this is one of the last here in Africa, in Namibia, a large number of people infected. And what is important in these outbreaks is the high mortality rate during pregnancy. So these outbreaks even from mother and child, the mortality is very high due to fulminant hepatitis in these pregnant women, and also for newborns, high prematurity rates. In other parts of the world, particularly in Europe, genotype 3 and genotype 4 are the most frequent genotypes. And in these countries, it's a zoonotic disease, and also related with blood transfusions. And the main route of infection is consumption of infected pork. There is usually clinical asymptomatic cases, and particularly affects older men and can produce chronic infection in immune-suppressed individuals. And also is associated with extrahepatic manifestations. So if you look at the different hosts where epiviruses are identified, so we can see that rabbit, camel, wild boar, porks, different animals, and also there are some others that are only specific for animals, like other genotypes, genotype 5, 6, 7, and 8, that we can find in rats, bats, ferrets, and fish. The main route of transmission of genotype 3 and 4 is consumption of food, food infected with hepatitis C virus, usually raw food, or crops or shellfish, but also can be transmitted, direct transmission, by contact with infected animals, and another option is through blood or blood products. In Europe, the main cause is particularly meat food, particularly undercooked or raw food. Looking at the clinical manifestations of hepatitis C virus infection, the majority of cases are completely asymptomatic infections. There is a small proportion with clinically apparent acute and chronic hepatitis, but there is an important fraction of patients that have neurological syndromes or extrahepatic manifestations. Let's start with liver diseases, and it's the main cause of acute viral hepatitis. These are data from our hospital showing that hepatitis E virus is the second cause of acute viral hepatitis. There are also several reports from Egypt showing that approximately 10–20% of acute viral hepatitis here are also related to hepatitis E, and it's cause an important number of hospital admissions, and we have one case that died from acute and chronic hepatitis E. The diagnosis of acute hepatitis is based on the detection of viremia. RNA is detected very, very early, very shortly before onset of symptoms. And usually acute hepatitis E, in the majority of cases, it's an auto-limited infection, and almost all patients recover from this infection, except in immune-suppressed patients, that these patients can fail to clear infection, can progress to chronic hepatitis, and this is particularly true in solid organ transplant recipients, particularly kidney transplant recipients, patients with hematological disease, individuals living with HIV, and other patients receiving heavy immunosuppression. So the recommendations, the EASL guidelines recommendations for hepatitis E virus infection is to test all patients with unexplained abnormal ALT livers, particularly if they are under immunosuppression. These patients, immunosuppressed patients that have an acute infection and at the end reach a chronic infection, usually due to the immunosuppression, have a more rapid progression of the fibrosis and to liver cirrhosis, and some of them even die or need a liver transplantation. Let's now focus on the neurological manifestations. These are the most important extrahepatic manifestations, and I think now our task is to educate neurologists on these neurological and extrahepatic manifestations associated with hepatitis E virus. One of the most common is neuralgic amyotrophy, also called Parsonage-Turner syndrome, that it's an acute and painful unique or multiple mononeuropathy in the upper extremity. Usually it's very, very rapid. It's associated with motor weakness, amyotrophy, and loss of sensitivity. And it was this neurological amyotrophy has been found in 10% of the patients with the neurological amyotrophic. There is acute hepatitis C. These patients have serological markers of hepatitis E infection. And usually when the neurological amyotrophy is associated with hepatitis E, it's more often bilateral asymmetrical involvement that in cases of neurological amyotrophic not associated with hepatitis E virus. Usually it can happen in patients with acute and also chronic hepatitis, and usually is self-limited. The other neurological syndrome associated with acute hepatitis C is the Guillain-Barre Syndrome, and these are several studies in France, in Belgium, in Japan, showing that patients with Guillain-Barre have a higher prevalence of markers of hepatitis E infection, and this is completely different in healthy controls. So clearly, Guillain-Barre can be associated with hepatitis C, and cases of acute hepatitis E infection have been found in pediatric patients with Guillain-Barre syndrome. These neurological manifestations, and this is data from the French National Reference Center, in more than 200 acute hepatitis C cases, you can see that immune-competent patients, the possibility of having neurological symptoms is more frequent than in immune-compromised patients, and particularly neurologic amyotrophic and the Guillain-Barre syndrome. Other neurological manifestation associated with hepatitis E is meningoencephalitis. And there are other organs that can also have extrahepatic manifestations, such as renal, hematological, and even acute pancreatitis, arthritis, and myocarditis, or even autoimmune thyroiditis. Outside of the neurological manifestations, the most important is the renal manifestations, particularly the membranoproliferative glomerulonephritis that usually can be associated with mixed cryoglobulinemia. And this is a situation that it's also important to test for hepatitis E infection. These extrahepatic manifestations that are associated with hepatitis E infection, the mechanism of action is still unclear. And currently, there are two possible explanations. One, it's related to hepatitis E virus replication, and other possible explanation is throughout an immune-mediated reaction, particularly throughout T cells and macrophages mediated cell lysis. Hepatitis C virus has been detected in different tissues or body fluids, such as neuronal cells, in cerebrospinal fluid, also in urine, in the placenta, in the breast milk, and this could be a potential mechanism by direct toxicity, but the other potential mechanism is immune-mediated. What are the recommendations in patients with extrahepatic manifestations, particularly patients that have this disease, neuralgic amyotrophy, Guillain-Barre Syndrome, encephalitis or myelitis, or proteinuria, and mild elevations on ALT levels? The recommendation is to test for hepatitis, even in patients with normal ALT levels. How to test for hepatitis E? Clearly looking at IgM anti-HIV antibodies and HBV RNA. These are the two markers of infection. And just to be on time, I would like to finish with treatment and prevention of hepatitis E. The recommendation to treat hepatitis E is for patients with chronic hepatitis E, and these patients usually are under immunosuppression, so the first step is to reduce immunosuppression. There are two potential drugs for treatment of hepatitis E, ribavirin and interferon alpha. There are more data supporting the use of ribavirin, and there is also a vaccine that we can use to prevent this infection. The only issue is that this vaccine is only available in China. Thank you very much for the invitation and for the attention.
Thank you, Dr. Buti, for excellent talk. I want to ask about management of pregnant women infected by acute hepatitis E.
Yeah, the management of pregnant women with acute hepatitis E, it's a supportive management. Usually ribavirin is not recommended, particularly during the first and probably the second trimester of pregnancy, because it's teratogenic. So the management is like other acute hepatitis, and if in case of fulminant hepatitis, then we need more supportive treatment. But there is not a special drug that we can give during pregnancy, and particularly in case of fulminant hepatitis.
One study give sofosbuvir during pregnancy because it's safe.
Sofosbuvir?
Sofosbuvir.
Yeah, the data available, and there is a study in Germany treating patients with acute hepatitis E with sofosbuvir. The study was negative. And because the study is negative, I think we don't recommend this.
Especially in acute severe hepatitis E with complication, DIC, and bilirubin more than 1 month.
There is no evidence that sofosbuvir works in hepatitis E virus. So I think the recommendation is not to give sofosbuvir.
Thank you, Dr. Buti.
Thank you. Any questions from the floor for Professor Buti? So thank you very much, Professor Buti.
Through the Hepatology on the Nile 8 conference organized by Liver Institute, Monrovia University, I pray to God long live Liver Institute, and may God have mercy on its founder, principal of investigator, Professor Yassin Abdel Ghaffar. Under the title of postgraduate course, Viral Hepatitis Session, I want to introduce the Professor Martina Muller, Professor and the Chairman, Department of Internal Medicine, Gastroenterology, Hepatology, Endocrinology, Rheumatology, and Infectious Disease, University Hospital, Regensburg, Germany.
Thank you so much for the kind introduction. Dear Chairman, dear moderator, dear colleagues, I'm happy to be here. Thanks for the invitation. Let me just introduce myself briefly. As you've heard, I'm from Germany. I'm chairman in one of the 6 Bavarian university hospitals that is in the south of Germany. And this is my department. This is patient care, research, and teaching. And we have a strong focus on hepatology, endoscopy, intensive care, but we do other things in addition. And we have a special focus on interprofessional care. That means different professions work together. And we have started 2 student wards, and I happily invite you to visit us, because these students' wards are really, really inspiring, because they motivate people. This is a science cover from the 11th of March, so very, very recent, and I like to recommend this cover to you. And as you can see here, I have introduced a QR code for you for your convenience, so that you can access to all the literature that I have screened for this talk. And you see the green background, which stands for the UEG. And I am here as the chair-elect of the National Society's Committee of the UEG, and I give you greetings of this umbrella organization and of the current chair, Dan Dimitrashku. And this National Society's Committee, it integrates 48 countries and their national societies, and I promise to visit them all, and your country is the first. There's not only the pandemic, as you heard from Maria Butti, it's also a war that really concerns us. And I'd like to share with you the statement of the UEG on this war. The UEG stands in solidarity with Ukraine and calls for an immediate stop of the war. We will do everything in our power to help and support those who are in need in Ukraine. So, to the talk. This is the agenda. It will tackle all I've found that was published in the last 2 years about SARS-CoV-2 and the GI tract. Let's look at these dashboards. So the good thing, the best of Corona, of this pandemic, was that we share data, that we have new platforms and dashboards. But there is also sad news on it. As you can see, Germany today is in number 2 of the incidence. Your country here, Egypt, is number 71. So you're doing extremely good. This is the virus. And it's familiar, almost structures. You see the spike glycoprotein, which allows this virus to enter the cell by docking to the ACE2 receptor. And this is a summary of the SARS-CoV-2 variants of concern and all the journey that we have gone so far in the last 2 years. So we're coming from alpha, beta, gamma, delta to Omicron. And this goes along with this terrific way that we had a vaccination, very, very rapid, but along went also the escape of the virus. And you can see here the Omicron new variant, which is now the variant worldwide. And we have already 3 subtypes of Omicron. The thing that the virus did here is that it introduced 10 new mutations in 1 variant and 10 on the receptor binding protein. That is its key to the cells. And key to the cells, so the variants we know, alpha, beta, and delta, they used cell surface fusion to enter the cell. And it's just the RNA, as you can see here, that resides in the cell. The new variant, Omicron, prefers to use endosomal fusion, but is smart enough to use both routes of infection. So, and that allows this virus to infect. Of course, it has a second key and can infect more cells, humans as well as non-humans. And may I draw your attention to this serine protease called TMPRSS2. This helps the virus to dock to the ACE receptor and to infect the cells, and this is a drug target with ongoing studies. So, new virus, new mutations, new routes of infection. SARS-CoV-2 does not only affect the respiratory tract, and this is the focus of the talk, it has a lot of gastrointestinal manifestations. It's an extremely clever virus that by hijacking the ACE system, the renin-angiotensin-aldosterone system, can affect the kidneys, the liver, the lungs, and the GI tract. And so this is enormously smart if you think about it. So the virus ensures that it's shedded via the kidneys, that it excreted in the stool, and that gets out when you cough. So this is why this is a particular attractive system for a virus. And this picture shows you it's not only infection that we are dealing with, it's inflammation, and it's also thrombosis and ischemia. And this is what the virus can do. GI symptoms have been reported in 7 to 52% of patients. Why is this so? Because there are more ACE2 receptors in the gut than in the lung. You have to remember this. And every inhaled virus has the potential not only to cause damage to the lung, but also to the entire GI tract. And this is how the virus does it. We have seen it binds via the spike protein to the ACE. This ACE protein is then downregulated. This is the intestinal mucosa. And this leads to a decline of the anti-inflammatory ability of the mucosa. That threatens every human being because this is the contact with the outer world. So the anti-inflammatory abilities of the mucosa decline. In addition, after binding, and it's angiotensin 1 to 7, which is a very good protein, which normally is anti-inflammatory, but this protein is downregulated, so we get inflammation in the endothelial cells. We do not only get inflammation, we get also a disturbance of the intestinal microbiota. I have explained this, and you have all the barcodes if you want to read that in depth. But just remember, it's not only infection of the epithelial cells, it's also disturbance of the microbiota, and it also affects all the intestinal vessels that we have. And in any case, leads to infection of the endothelial cell, the epithelial cell, and to dysbiosis. And this explains why we have so many gastrointestinal symptoms. You see, every endothelial cell in our stomach or gut can be affected. This explains why there may be ischemia in the bowel, and these are the major complications. This is a study that was just published in Gastroenterology in a non-human primate model that clearly shows that if you inoculate either via the stomach or intranasally SARS-CoV-2 virus, it leads to dysfunction of both, not only the respiratory but also the digestive system. This is the take-home message and absolutely important. And remember, it's epithelial cell, endothelial cell, and dysbiosis. And this explains all the complications and long COVID symptoms. To the symptoms. We have already heard 7 to 53%. I've brought with me in this barcode all the relevant studies for that, so you can read that. And which symptoms are the most often reported? It's diarrhea, nausea, vomiting, abdominal pain, and abnormal liver function test, which will be tackled by a separate talk in this session. So I'm concentrating on GI manifestations right now. So these are the well-known GI manifestations, and on the right side, you have the complication. These ranges from acute pancreatitis to intestinal obstruction to bowel ischemia to hemoperitoneum to abdominal compartment syndrome. These are our patients in my intensive care unit. You see on the left a bowel obstruction, thickening of the bowel wall. You see that on the ultrasound. You struggle for these patients, but we have to be aware of all these complications that can occur during the course of intensive care. The situation concerning whether GI symptoms are associated with a milder or more severe course is, the study situation is controversial, so there is no answer to that right now. What to do? You rule out other causes of GI symptoms and its supportive management. We do not have a specific therapy established, as you all know. Endoscopy. What did the virus do to endoscopy? So the first patients endoscoped were those who had apparent bleeding, who had to be scoped. And the most prominent features are the ischemic features in the colonoscopy. And this may represent an intestinal microvascular injury, as I have explained, via damage to the endothelial cells. This is a patient, again, from our intensive care ward who was super infected with cytomegalovirus virus when he was treated because of SARS-CoV-2 infection in our ICU. These are the patients that are referred to us as a transplant center, those who get secondary sclerosing cholangitis due to COVID-19. You see the casts, you see the verifications of the intrahepatic bile duct system, and often only liver transplant can save and cure these patients. There was an ongoing study, and 121 centers precipitated from 35 countries, and they were asked, what does the virus do to your endoscopy routine and procedure? And you see, they all said we had a severe reduction in our endoscopy volumes during the first peaks. The trainings were severely impacted. The training was severely impacted. Relative low infection rates in the endoscopy personnel and upon testing of asymptomatic patients. So that was what they reported. That is my reality, and I'm sure that was yours. So teaching was only possible via virtual and online teaching, and also patient counseling. And this is how my workplace looks right now, and I use it not only for conferences, but also for counseling. SARS-CoV-2 and GI cancer. The monthly numbers of colonoscopies in England, but this is just an example, the same was true for every country. You see that sharp decline was the beginning of the pandemic. And that was not only true to diagnostic procedures, but also for operations undertaken for colorectal, colonic, and rectal cancer. Sharp decline, and then it's getting better, and we have to work hard to address these patients. And this is not only true for GI cancer. I just wanted to put that there. You see breast and lung, and you have the same picture. So there's a lot of workload by SARS-CoV-2, and also a lot of workload by taking care that patients without SARS-CoV-2 are treated and diagnosed correctly. This is the impact on pancreatic carcinoma. After the lockdown, the number of borderline tumors decreased, while advanced diseases increased. So the same picture in every cancer entity. SARS-CoV-2 and IBD. There will be a lot of lectures on IBD, so I really concentrate on SARS-CoV-2 and IBD. You know that our patients were really concerned with IBD if they should get vaccinated, and the answer is yes. Although the seroconversion may be lower, the answer is yes, and we call for not only two shots, but also for the booster in these patients. So, and then there was the answer, which, if this is specific drugs used for IBD, are responsible for the lower rate of seroconversions. And yes, that is the case. So patients with immune-mediated inflammatory diseases had lower serologic responses after both doses of mRNA vaccines, and anti-CD20 and anti-tumor necrosis factor were associated with lower serologic responses. You can see this here, that some therapies were related to lower antibody responses. And this is a very recent, very brilliant study just in the Lancet. So for patients with IBD, the immunogenicity of COVID-19 vaccine varies according to immunosuppressive drug exposure. It is attenuated in recipients of infliximab plus thiopurines and tofacitinib. But however, the most important thing is that the patients with IBD have to be on stable treatment. And this is why the editorial asked, how significant is this? Because your first goal should be treat the patient adequately. And you see that here, that especially the combination of thiopurines and anti-TNFs leads to lower responses. But there's also good news. Anti-TNFs and ustekinumab were associated with favorable outcomes when patients with IBD got infected. And this again speaks for this inflammatory processes that the virus initiates. So people with IBD that are on anti-TNFs or on ustekinumab had favorable outcomes if they got infected with the virus. So this is enormously important. So people should stay on their treatment for IBD. They should be vaccinated, and there are some treatments that even show favorable outcomes upon infection. SARS-CoV-2 and long COVID. After we have struggled for our patients on the intensive care and are happy to have their lives saved, they are often months or weeks and years, they have symptoms and that really impair their life. And we call this long COVID, and we're still working on the definition. And you know this table already. It's the symptoms, the gastrointestinal symptoms in red, and these are the acute and the post-acute symptoms. And these are the symptoms of long COVID. And you see that patients having recovered from this COVID infection, that they further go on with abdominal pain, bloating, nausea, loss of appetite, loss of weight. So these are patients that really in our outpatient clinics that you should ask how they feel and often do not report all these complaints. So the GI tract in COVID, I sum this up, is essential as the pulmonary tract for the acute phase, post-acute phase, and also for long COVID. Thank you for your attention, and I hope I can have you in Germany. I put a lot of bonus material in this talk, so if you are interested in, this is like entry of the virus, drug development, new pathogenesis, new pathways, and also monoclonal antibodies. So if you're interested in this, just write an email to me, and I hope I could share with you my search on this very important topic for us. Thank you.
Thank you, Professor Martina, and we'll postpone the questions till the end of the session.
Now we'll move to the next talk, Professor Barbara Herold. Professor Barbara is consultant hepatologist, gastroenterology, and liver unit, Sheffield Teaching Hospital, National Health Service Foundation, Trust, United Kingdom. Professor Barbara will talk about liver disease, COVID-19, and immunization. What do we know so far? Professor Barbara will be with us live through Zoom. Unmute mic, Professor Barbara.
Hello, can you hear me? Hi. I'm sorry that I can't be in Cairo today. I'm just trying to share my screen to bring up the presentation.
Share a screen, please.
Does not. I'm trying to share my screen. I'm just looking for. I had opened the presentation.
Yes.
Yeah, and just starting on the first slide. Hello, my name's Barbara Herald. I'm very grateful for Professor Booty for allowing me. Oops, sorry, that's the wrong. Sorry, I don't know why this comes up. I'll try to change that. And I'll try to.
Now you can start.
Yeah, I don't know why this presentation comes up. I have to stop again. There's some problem with the screen sharing. I've pre-recorded it, but I'm happy to talk live, and it seems to be giving me the pre-recorded rather than the or I have to use an earlier version which isn't pre-recorded. So I'll try this. I do apologize for the hiccup.
Can we get the recorded lecture?
Okay. Okay. Can you hear me now? Hello. My name's Barbara Herald. I work at the liver unit in Sheffield, UK, at Sheffield Teaching Hospitals, and it's my pleasure to talk today on COVID-19 and liver disease. I will briefly cover the liver injury in COVID-19 and also talk about the cholangiopathy the previous speaker referred to. I talk about the cause of COVID-19 in patients with chronic liver disease and transplant, varying etiology and severity, and more in detail about COVID-19 and autoimmune liver disease, in particular AIH, and briefly touch on the impact of COVID on UK liver services. Not defined as liver damage during disease progression or treatment of COVID-19. It's been reported early on from March 2020 with the first publication, and the rates range from 8 to 78% of patients with an average about 44. The higher the ALT, particularly if jaundice is associated, the more severe the COVID-related disease and the poorer the outcome of patients.
Excuse me, Professor Barbara.
Yeah?
You want us to play the pre-recorded, don't you?
No, no, I don't.
But we can't see the slides. We can't.
Oh, 1 second. That is weird. I'll try again. I'll go on to share screen. COVID-19.
Yes, share PowerPoint.
Share PowerPoint. Okay. I'll just move to the slide where I was on. It was
full screen, please. Can you make it full screen?
Yeah. Can you see it now?
Full screen, please.
Oh.
Yes. Okay.
It's a pre-recorded version again, which I didn't want. I'm trying to get a non-recorded version on.
Can you share the screen? Full
yes,
screen, please. Full screen.
I'm screen sharing.
Can you just make it full screen? Can you make it full screen, please?
Yeah.
Okay, that's perfect.
Can you see it now?
Yeah, perfect.
Perfect. Okay, I'll start with the beginning of the slide, and apologies, I'm not the IT, but I'm afraid. So liver disease, COVID-19 related liver injury has been reported early on, and there is an association of severity, of the height of ALT and severity of disease. There is no one distinct histological pattern, and there's 4 different mechanisms by which COVID-19 causes liver injury. And it's part of the hyperinflammatory reaction with high inflammatory markers ferritin, CRP, D-dimer, interleukin-6, leading to cytokine storm with activation of innate and adaptive immune system. There's also direct cytotoxicity with the virus entering particular cholangiocytes as well as endothelial cells via the ACE2 receptor. There are particles of virus found in hepatocytes, and it can induce steatosis as well as mitochondrial dysfunction. Also, the systemic hypoxia and ischemia, like in the context of cardiomyopathy related to COVID-19, causes liver damage. And finally, our drug treatment can cause liver injury, in particular drugs like lopinavir, ritonavir, tocilizumab, and remdesivir. There's evidence that autoimmune diseases, including autoimmune liver disease, can be triggered by COVID. Most abnormalities are a transaminitis with or without jaundice, but there are case reports of secondary sclerosing cholangitis, which occurs in about 1% of ITU admissions and 4% of ventilated patients. Today, this is of last week, there were 30 case reports reporting on sclerosing cholangiopathy. They're associated with severe COVID manifestation, the need for ECMO and inotropes, as well as dialysis, predominantly affecting men and those with a high rate of comorbid conditions. It occurs on or after the ITU admission, while other features of COVID-19 may improve and is associated with a high mortality. Survivors show progressive changes if serial MRCPs are done, and the only long-term cure is liver transplantation. It is felt that the secondary sclerosing cholangitis in COVID is a multi-hit event. There are COVID-related issues like infection of cholangiocytes and epithelial cells due to through the ACE2 receptors. IL-6 is involved in endotheliopathy and coagulopathy and the liver damage sustained in COVID. IL-6 also stimulates endothelial sinusoidal cells to produce procoagulant factors like von Willebrand and factor VIII, pro-inflammatory chemokines, and adhesion molecules, ICAM and selectins. There's a resulting microangiopathy, which affects both the hepatic artery tributaries and the portal vein tributaries, and their sinusoidal outflow obstruction. Hypoxia leads to ischemia and necrosis, biocast formation, and ultimately stricturing. DILI can be involved and cytokine storm can be involved, and it is felt that there must be at least 2, but probably more than 2 hits to sustain secondary sclerosing cholangitis. What is the impact on patients with liver disease? Annually, about 2 million people die due to liver disease, making it the 11th most common cause of death. The impact on liver patient depends on the liver disease, the severity, and comorbidity. Impact can be direct, via infection, or indirect, with increased anxiety restrictions, reduced screening for case finding for HCC or for hepatitis C or HCC surveillance. There's reduced face-to-face contact and increased use of technology as alternatives to face-to-face clinic review have been explored and are likely to stay beyond the pandemic. Many patients altered their lifestyle and not necessarily to the Brexit. We already see an increase in alcohol-related admissions in the UK, and the rate of NAFLD is also likely to increase. A number of studies looked at risk factors and high-risk groups. One of the first of these studies was an Italian multi-center study which looked at 50 patients admitted in March 2020, right at the beginning of the pandemic in Europe, with cirrhosis, and assessed their 30-day mortality. The median age was 67, 70% of patients were male, and the predominant etiology was viral hepatitis and ALD. 60% were community acquired, 20 had recent healthcare contact, and 20% got infected during admission. There was evidence that the liver disease was worse at the diagnosis of COVID compared to the last clinic visit, with dropping albumin, raising bilirubin, and an increase in the MELT score. 17 patients died at a median age of 70, 2/3 from respiratory failure and 5% from liver failure. Negative predictive factors were a high Cliff organ failure score, a MELT over 15, and moderate to severe respiratory failure. Compared to patients hospitalized for bacterial infections, those hospitalized with COVID had a higher mortality despite a lower MELT, with a mortality of 34 versus 17%. A further study from the USA had a much bigger cohort of over 850 chronic liver disease patients with a younger median age and 55% male patients. The predominant diagnosis here was NAFLD, followed by hepatitis C, alcohol, and hepatitis B. Just over a quarter of patients were cirrhotic, and just over 10% of the overall cohort were decompensated. It has to be said that most patients with alcohol liver disease were cirrhotic, which did not hold for other groups. 89% were symptomatic at diagnosis, 60% were admitted, and 61 fulfilled the criteria for severe COVID. The risk of liver-specific death, the liver-specific risks were etiology of ALD, child B or C cirrhosis, and the presence of HCC, with increased hazard ratios. Generic risk factors, as expected, were increasing age, COPD, hypertension, and smoking. Hispanic ethnicity had a higher risk of severe COVID compared to other ethnicities, and while COVID triggered decompensation, most of the deaths were related to COVID-19 and not to chronic liver disease. In transplantation, there was an initial decline of liver transplantation due to the concerns of the severe immunosuppression required post-transplant, and the patient on the transplant list who were stable were deferred, and only the sickest patient were transplanted. However, it transpired that the risk on the waiting list was higher than the risk of transplanted patients. Looking at transplanted patients, the main risk factors were age over 70 and the presence of diabetes and CKD, and the overall outcome was similar to matched controls. There was an impact of immunosuppression with MMF associated with an increased risk of severe COVID, whereas this risk was reduced in those on tacrolimus. And negative transplantation with higher immunosuppression was not a negative predictive factor for outcome. So the risk factors for poor outcome are those as in the general population, but also cirrhosis, as the immune dysfunction is associated with a higher susceptibility to infection, both bacterial and viral. It can trigger acute and chronic liver failure and worsening of cirrhosis. Patients with cirrhosis have an increased mortality compared to cirrhotic patients without COVID, but also compared to non-cirrhotic patients or non-liver disease patients with COVID. To reduce the risk of cirrhotic patients, it is important to have COVID-free zones for elective bonding and paracentesis and to continue prophylaxis. Alcohol-related liver disease is also associated with immune dysfunction, but also high risk behavior of the patients, so there's a high rate of infection. Alcoholic hepatitis and COVID has been reported, and if suitable for treatment with steroids, these should not be withheld despite the later clearance of the virus, as there is associated reduction in mortality. Patients with NAFLD do not have an increased risk of infection, but a risk of a poor outcome because of their comorbidity, namely diabetes, hypertension, kidney disease, and the metabolic activity of the fat with baseline increased cytokine levels and chronic inflammation. Immune dysregulation in HCC leads to an increased risk of infection, whereas viral hepatitis does not produce a higher risk of infection or poorer outcome, but there have been case reports of fulminant hepatitis in the context of chronic hepatitis B. What about immune hepatitis? This can be relating to COVID as well as 19, as well as vaccination. There are 3 case reports of patients developing AIH during COVID or shortly after, responding well to the standard treatment. There are more case reports, including our study from Sheffield, showing AIH following vaccination. All 3 vaccinations, Moderna, Pfizer, and AZ, have been implicated. The time interval ranges from 3 days to a month, and some patients had 2 vaccinations, others only 1, high transaminases, high immunoglobulins, and positive autoantibodies, good response to treatment. Is this due to a trigger, or is it the cause of AIH? There's 3 putative mechanisms, with molecular mimicry being one, epitope spreading and bystander activating being the other. The latter 2 would indicate that the vaccination or infection are a trigger of AIH in predisposed individuals and are currently felt to be the most likely cause of the occurrence of AIH post-vaccination and infection. There's a number of open questions. Will vaccine-induced AIH behave like drug-induced liver injury, and can immunosuppression be withdrawn? We don't have data for this. Should patients who had COVID due to vaccination, who had developed AIH from COVID or vaccination, be having further vaccinations? The report from ZOO seems to favor this, and we certainly advise our patients to have vaccinations. Up until last week, I probably would have said here that we also counsel our patients to be slightly more relaxed, but given the recent spike in infections in Europe, I wouldn't give that advice at the moment. There's 3 studies looking at COVID in patients with AIH. They're all multi-center retrospective studies preceding the use of vaccination in our patients, and they compared to other chronic liver disease and those without liver disease. Looking at the rare disease register in Europe, the rate in the first 6 months of the pandemic up to July 2020 was low, 0.36 to 0.66% of patients. It was mainly larger centers reporting autoimmune liver disease cases with COVID, and the reported case rate is almost certainly not equal to the infection rate. The 3 studies are difficult to compare as they report slightly differently and also have different patient populations. In the first study, patients were older, had a higher rate of cirrhosis and hospitalization, and mortality was higher at 20%. And in the latter 2 studies, mortality fell. The third study is an extension of the second study, but appeared to show for the first time a negative impact of immunosuppression on survival if there were on immunosuppression at diagnosis. There were limited data on alteration of immunosuppression. The third study also showed more severe COVID in those on TAC or MMF, which was not found in the other studies. And AIH activity did not impact on survival in the largest cohort. Compared to other chronic liver disease patients or matched non-chronic liver disease patients with COVID, they had no increased risk of death and no increase of the risk of severe COVID in 2 of the 3 studies. Mortality predictors were age, cirrhosis, and in 1 study, hypertension. We looked at our experience in Sheffield, as several patients did talk about symptoms relating to long COVID. We have a cohort of about 350 patients with autoimmune hepatitis, with a median age of 61, 79% female, 91% Caucasian, and approximately a third cirrhotic. Between March 2020 and February 2022, 73 patients were infected with COVID, with a median age of infection at 58. 11 were admitted, 7 for COVID, 3 with an incidental finding of COVID on admission in screening, and 1 hospital-acquired infection. 2 patients died from and with COVID, compared to 19 patients dying from other causes with a slightly higher median age. 2 patients were infected twice. 9 patients infected prior to having had any vaccination, 3 refused vaccination, and then there's an increased number as time goes by. 9 infections occurred in the first 12 months of the pandemic, 26 between April and September 21, 18 from October to December, and 19 in the first 2 months of 2022. Comparing infected patients with those who did not suffer infection, there was a slight reduction in the uptake of vaccination in those infected, excluding those who were admitted with COVID, who are very likely to accept further vaccines. We knew about several patients with long COVID, which triggered our review, but we found a lot more patients with COVID who didn't tell us about infection during clinic appointments, who were asymptomatic or had only mild symptoms. The anxiety level of patients with AIH varies. Some of our patients are exceedingly anxious and are still effectively shielding, while others are much more relaxed. The shielding was effective, as shown in the very low infection rate in the first 12 months, but by now it is similar to the overall rate of infection both in Sheffield and the UK. COVID and liver services. There's a lot of unknowns both for patients and healthcare professionals with COVID, and there's still new challenges to come. We're catapulted a decade ahead, starting to use telephone and video consultation a lot more frequently, and the uptake varied between patient groups. Some of my older colleagues and the older patients were really unhappy with video consultation, whereas the IBD group very much embraced video consultation. There were technical difficulties, and we have found that our alcohol patients tend to underplay the symptoms and alcohol consumption in the non-face-to-face encounters and do not attend for the regular blood test and then get admitted with significant decompensation. We early on got COVID-free pathways for bundling program and paracentesis, and this has been the case all across the UK. After an initial impact on HCC surveillance and screening for liver disease, this seems to have been ameliorated during 2021. We will see more work due to the lifestyle changes engendered in the pandemic, and I think many of the changes to our services will persist. And I finally would like to summarise by saying the standard risk factors apply to patients with chronic liver disease as well as to anybody else. The liver-related risk factors are those expected. Cirrhosis, particularly advanced cirrhosis, ALD and HCC, are relating to poor outcome. Transplantation and immunosuppression in AIH do not generally predict a poor outcome. Autoimmune diseases, including liver diseases, can be triggered both by COVID and by vaccination, and not all immune alteration is equal. Targeted immunosuppression seems to do better than immune dysfunction in the context of HCC, ALD, and advanced cirrhosis. Secondary sclerosing cholangitis is rare, but requires attention and close follow-up and referral for transplantation. We don't know the full impact of the vaccination, but there appear to be some signals for patients, at least until very recently, and for medics as well as to relax. But I think we have to see what the next few months will hold. Finally, I would like again thank Professor Alam and the organisers for kindly inviting me to give this talk. And I would like to thank my colleagues, both medical and non-medical, and our patients at the liver unit in Sheffield. And I'm happy to answer any questions. I have no disclosures.
Thank you, Professor Barbara, for this talk. And please be with us till the end of the session for
Sure.
if there is any questions.
Sure.
Question?
Now we go with other zone with Professor Tariq Asila, Professor of Medicine, Paris University, Hepatology Department, Head of Viral Hepatitis Team, with interesting talk about expanding Hepatitis B viral treatment criteria, new biomarker, and future treatment. Live Zoom.
Dear colleagues, ladies and gentlemen, it's a great honor and I'm very pleased to present at the 8th Hepatology on the Nile with my colleagues from Egypt. The title of this lecture is Expanding HBV Treatment Criteria, New Biomarkers and Future Treatment. These are my disclosure. So this is the agenda. First, the Hep C success story has led to a major hope for Hep B drug development. We will discuss on HBV virology, natural history, physiopathology, new biomarkers, HBV cure, HBS loss, drug development, and finally, with some take-home messages. You know that Hep C, direct-acting antivirals, has been a huge revolution. Many drugs with different mechanism of actions have been developed, protease inhibitors, NS5 inhibitors, polymerase inhibitors, leading to fantastic treatments. You see all the chemical structures of many drugs which have been developed in very few years. And you know how it is difficult to make drug development with available treatments, and fortunately for our patients, many of these drugs are now available. As two examples, you can see sofosbuvir, valpatasvir, the Astral studies, and on your right, the Glecaprevir Piprantazvir studies. And you see that for the patients, we reach almost 100% cure with sustained virological response in almost all the patients, and with an excellent tolerability and safety profile. So it's a fantastic drug revolution. However, job is not yet done. How to achieve Hep C elimination? We have to increase prevention. We have to increase test and treat strategy and awareness to make altogether Hep C elimination possible. Let's speak now on HBV, virology, and natural history. In 1967, there was a discovery of HbSAg Australia by Blumberg, which led to the Nobel Prize of Medicine. And you can see many steps have been done with electronic microscopy, the DEN particle, serological markers, the sequencing, the vaccine, and more recently, the identification of the receptor NTCP. Hep B, as you know, is a major worldwide burden. There's around 260 million of chronic Hep B patients. It's the first cause worldwide of cirrhosis, hepatocellular carcinoma, and it leads to around 1 million deaths per year. There has been major improvement in therapy, and there is an excellent vaccine. However, implementation is not well done all over the world. The variance structures, we have the Hbv variant, which is a complete infectious particle, but we have also empty particles. There's the nucleocapsid, the envelope, and the DNA. The Hbv genome organization, it's an enveloped partially double-strand DNA virus. There's a compact genomic structures. There's 4 overlapping open reading frames. There's a reverse transcriptase DNA polymerase, and it encodes 4 sets of viral proteins, HbSAg, HB core-Ag, viral polymerase, and HBX protein. The Hbv replication sag, it's very important to know because each step is a potential target for drug therapy. You have Hbv M3 with the receptor NTCP. You have the transport to nucleus, the CCC DNA formation, CCC DNA for covalently closed circular DNA, which is a mini chromosome in the nucleus, and it is believed that it is the cause of the persistence of the infection. You have transcriptions, translation, encapsulations, DNA synthesis, and finally morphogenesis and secretions. And you have release full particle but also empty particle. It's believed that this empty particle can exhaust the immune system and allow the virus to escape to the immune system. Each step is a potential target for drug development. And we have also the immune system. If we help the immune system, we can help to clear the infected hepatocytes. Let's move to physiopathology and new biomarkers. Fibrosis is a major prognosis factors. We have many scores, and you have the Metavir score as example. F0, no fibrosis. F1, portal fibrosis without septa. F2, portal fibrosis with few septa. F3, numerous septa without cirrhosis, and F4 cirrhosis. And patients with F3, F4 are at high risk of cancer and end-stage liver disease, are a priority for therapeutics. We know that Hep B and Hep C induce mitochondrial dysfunction. We can have mitochondrial activation, inflammation, and it can lead to fibrosis progression. And we have written a review in gastroenterology on mitochondrial dysfunction and signaling in chronic liver disease, if you are more interested in this mitochondrial dysfunction. You see some data. You have healthy controls on your left, on your right, Hbv patients, and you can see that mitochondrial DNA levels are decreased in patients with Hbv infection when compared to controls. We have also multiple mitochondrial DNA deletion in patients with Hbv and advanced fibrosis when compared to healthy control or to patients with mild fibrosis. Furthermore, there's an altered mitochondrial function and decrease in ATP in Hbv infection. Altogether, we can say that there's a mitochondrial dysfunction in Hbv. What about HBS loss, Hbv cure? We know from old studies, this is a study performed in Italy with 309 patients with cirrhosis and a mean follow-up of 6 years. And you see that the patients who achieve HBsAg loss has a good prognosis. Those who did not achieve HBs loss has a decrease in survival linked to cancer and end-stage liver disease. So HBs loss is a surrogate marker of survival. You see the Hbv and the immune response. We have direct cytolytic activities on infected hepatocyte, antiviral immunity, non-cytolytic activity, and we have also neutralizing anti-HBsAg antibodies. By a better understanding of the immune response and the defect, the altered immune response, we could understand better and restore this immune response. So we do believe we may need combination therapy with direct antivirals and immune modulators. What about drug development? First, to start with a quotation from Ibn Sina, there are no incurable diseases, only the lack of will. There are no worthless medications, only the lack of knowledge. So it's very important that we all work together to improve knowledge and to develop new treatment. Hbv drug development has been also very important. Current treatments include pegylated interferon and analogs. There has been a fantastic enthusiasm with the success of Hep C cure leading to an intrinsic hope for an Hbv cure. And there is an urgent need to develop new therapies with a limited course that could cure Hbv infection. Nowadays, with analogs, we have to have a long life treatments. Of course, there are good treatments with high efficacy, good tolerability, but we need short treatment duration to cure Hbv, as we did it for HCV. You see that HBs loss is rarely obtained with current treatments. In HBe negative, you see that with entecavir and tenofovir, it's not achieved, and interferon is providing the higher chance to HBs loss with around 10%. What are the treatment goals for patients with Hbv infection? From bottom to the top, we have biochemical response, ALT normalization. We have partial virological response, Hbv DNA suppression. We have HbAg loss in HbAg positive. And we have HBsAg loss, which is a functional cure. If we eradicate cccDNA, we can have a sterilizing cure. And the most important is finally to improve survival, quality of life, to decrease cancer and end-stage liver disease. However, these are very long-term benefits, so we need surrogate markers of success as HBsAg loss. You see all the compounds in development, N3 inhibitors, cDNA targeting, epidrugs, RNAe, secretion inhibitors, next, capsid modulators, immunomodulators. I will give you now some examples of drugs in development. We have bulevirtide. It specifically binds to NTCP. It blocks the entry for Hep B and Delta infection, and it has been approved in Europe for Delta infection. It's a conditional approval. We need more data. You have siRNA. It's very interesting because it addresses full Hbv transcriptome. It's multiple triggers to avoid resistance and having coverage all viral genomes. And many of these compounds are in phase 2 of drug development with efficacy, and we need more data also in combination. We have capsid assembly modulators. Capsid binds to the Hbv core, which is a key protein in the Hbv life cycles. It forms a viral capsid. It's essential for Hbv replication and the formation and maintenance of cccDNA. It's involved in cccDNA transcription, and it possesses immunosuppressive activity. So it's why this class also is important in drug development. You can see a table with first on your left the mode of action and 3 inhibitors, capsid assembly modulators, siRNA, antisense oligonucleotide, HbS/Ig secretion inhibitors. You have then the stage of development, phase 2, phase 1. You have the compounds, you have the company, and then you have the clinical trials gov identification number. Of course, this development is ongoing, and we have each time to adapt because there's new trials that are starting. And it will be very interesting to follow this drug development for Hbv infection. Finally, dear colleagues, ladies and gentlemen, I'm very pleased to give these lectures among all my colleagues in Egypt. To summarize, Hbv is a major public health issue. We have to improve vaccine coverage. We have to improve screening. We have to improve understanding of physiopathology of viral cycle. HbS loss may be a surrogate markers, and the research by better understanding the virus replication cycle, we could develop an Hbv cure program. And we hope that there will be less COVID pandemic, and this is just a review that we published in Journal of Hepatology about COVID-19 discovery, diagnostic, and drug development, just to share with you if you are more interested in this issue. So with this, thank you very much, and I wish you an excellent meeting. Thank you again.